And I do wish you a very good morning on this cool spring day. Today's lecture is not necessarily going to be a very happy one, because you're going to learn about disorders that in fact affect the brain and mostly affect memory. And I want to make sure that I go through these slowly so that you understand the importance of keeping your brain very healthy. Now, this is not a very happy lecture, but next time we're going to talk about specific ways that you can decrease your risk for Alzheimer's disease and decrease your risk for loss of memory as you age. And so I'm going to end on a high note. Today is not it, okay? So everyone be prepared for that. I once gave a talk on Alzheimer's at a big lecture, and a little old lady came up to me and handed me a note, and on the note it said, "You're scaring me to death." And I felt terrible, and I thought, why would she come to a lecture? Never mind. Okay. So we're going to start with my ubiquitous review, but this is very brief this time. I think you've gotten the point. This is only part of the number of areas in the brain that play some role in memory. We focused on prefrontal cortex. What kind of memory? Working memory. How to keep the thread of an idea going for a short period of time. And also, up here, the hippocampal formation, which plays a critical role in short-term memory. And the hippocampus also has to process information before it gets put onto the cortex in general for long-term memory. So we've only focused on these two areas. But what's important is if you damage any of these areas, and many others that aren't on this slide, or the axons that connect the various areas. So notice that all these areas are interconnected with each other. Another basic point about neuroscience is that when a neurologist sees particular signs and symptoms, they know where the lesion is at in the brain. It's called the anatomic diagnosis. But what's important here, let's say the hippocampal formation. You have a problem there, you have a problem with short-term memory. That doesn't mean short-term memory is located in the hippocampus. It means the hippocampus is critical in the processing of short-term memory, which involves its interconnections with many other areas as well. So it's like a car. You know, if you pull something out, maybe the car doesn't run, but that's not where the car runs. It's just critical in the circuit that allows that to take place. I also want you to think about this. If you had damage to an area like this, all of the areas that are connected to it are also affected, because that is a critical component that has been removed from the normal circuit. Okay? So what we're going to talk about today is what can cause memory loss. This is really important. Basically any disorder that affects the nuclei or areas of the brain that process memory information, or affects the pathways that connect these areas, that would be the axons that connect the areas, can cause some type of memory loss. So you could have a disorder that is not specifically associated with memory loss, but if you lost, say, the axons between certain nuclei in your brain, you would have memory loss. Okay? So here I had to restrict this because we only have an hour, so I have to restrict what I'm going to talk about. So I'm going to focus on contusions and concussions, vascular events is your blood supply, seizures, what's called hippocampal sclerosis, which means hippocampal scarring, psychiatric illness and abuse, and neurodegenerative disorders. And I'm going to use Alzheimer's as the prototypical neurodegenerative disorder, or disorder in which neurons degenerate and die, as the major example of a disease that affects memory. So let's start with contusions and concussions. A contusion is a bruise. So what it normally means is that you're hit somewhere in the head, and because what is closest to the skull is going to be your cortex. Little tiny blood vessels break in the cortex when you're hit in the head, and so it's basically a bruise on the surface of the brain. So if I hit my arm really hard, I'd get a bruise on my arm from that, from the breakage of little blood vessels. And that's exactly what a contusion is, except it's a bruise on the surface of the brain. That is always bad. That is always bad because you don't regenerate neurons in the brain. We're going to talk about the major exception to that, but overall you don't. So if you destroy the blood supply to neurons, those neurons will die. Okay? So a concussion, on the other hand, is a transient disruption of electrical activity. Remember I said that neurons communicate electrochemical. So an electrical impulse in this neuron, the axon comes down, and it causes changes here that cause neurotransmitter to be released and causes an electrical change here then that then gets propagated that way to the next neuron. And so when you get your head really jarred, like you get hit in the head with a ball or a car accident or whatever. Many of you, I have had a serious concussion at one time. Transient disruption from trauma. There is a new terminology is being used. It is now being called mild traumatic brain injury. And there's a reason for that. So even a single concussion where you don't lose consciousness is called a mild traumatic head injury, okay? Even a single mild TBI increases the risk for Alzheimer's disease. Okay? Now, there's probably hardly a person in this room who hasn't had a concussion at one time or another. Risk is something, it's a tiny risk that it increases, but nonetheless it increases it. Repeated mild or severe traumatic brain injury is a significant risk factor for the development of what we call chronic traumatic encephalopathy. This is what's associated with like football players, boxers, other individuals who get hit in the head a lot, and for the development of many neurodegenerative diseases, Alzheimer's, amyotrophic lateral sclerosis or ALS, Parkinson's, and other diseases. Basically, you need to not traumatize your brain, bottom line. And this is why coaches need to learn about the brain, and we need to do things that we already have done some things. We make children wear helmets or adults wear helmets when they bicycle. They're talking about changing rules in soccer so that head hits of the ball are no longer allowed, that it will be feet only. Boxers, of course, you know that a boxer, a professional boxer in their career, is estimated to sustain some 50,000 hits to the head in training and in professional fights. So these individuals are at significant risk for the development, as you know, Parkinson's disease, Muhammad Ali, Cassius Clay, and other degenerative diseases, most specifically Alzheimer's, okay? Vascular events. This is a really important one. A lot of us don't get our head hit a lot, but how we treat our vessels in our body and our brain are very, very important. And guys, let's just stand back and think about this. The heart pumps blood to the brain and to the other organs of the body. If those vessels are not healthy, it's like a pipe that's full of crap. You can't get fluid through it. And without oxygen and glucose being brought to the organs of our body, including our brain, they can't function. If you can't get adequate blood supply and everything to the liver, you get liver failure. Your bladder, your stomach, your heart, everything, but your brain especially. And I'll come in a minute to why that is true, okay? Now, many of the areas that we've talked about in this class, and again, I'm having to restrict what we talk about because many of you, this is your first introduction to neuroscience, and I want to make sure they don't leave you in the dust of the detail, okay? Many of the areas, and specifically and importantly, the hippocampus, our little seahorse, which is involved in the processing of memory for short term and then sending it on for long-term memory, supplied by one artery called the posterior cerebral artery, or PCA, okay? Other arteries supply other areas that are involved in memory, but I'm going to focus on the PCA. Even unilateral strokes, where you have ischemic stroke, which means there's a decreased blood supply due to some blockage. So ischemia is just a lack of a blood supply bringing oxygen, or the rupture of a vessel, which is called hemorrhagic stroke. Either kind of stroke that involves the PCA can in fact produce memory loss, even on one side of the brain. And the reason for that, if you recall what we learned in some previous lectures, the left hippocampus is most involved with words and facts, whereas the right hippocampus is involved in spatial memory. So if you rupture an artery that supplies the hippocampus on the right, then you start having trouble with spatial memory because you've disrupted the hippocampus on the right. Now, unfortunately, this was poor design. The two posterior cerebral arteries arise from a single artery called the basilar artery or base artery, and I'm going to explain that in a minute. Thus, now let's just imagine this. Let's imagine that this is the basilar artery, and these are the two posterior cerebrals that come out of it. If you get one posterior cerebral artery, then you affect only one side of the brain, and you may have some specific memory loss, but you still have the other side of the brain normally functioning. Everybody with me? So your memory loss is going to be less. But let's imagine you have something wrong with the big vessel that supplies both of these. You stop the blood supply to both sides of the brain. Okay? So this is what I mean by poor design. Okay? So here's what I want to do. I want to orient you to this picture. Let's look at Fred here. And remember, Fred has two hemispheres. So this is the lateral surface, this is dorsal, and this is ventral. This image here is a ventral surface of the brain, which means you take Fred and turn him upside down and look at him. Okay? The entire blood supply to the brain is through two major artery sources. Your vertebral arteries, which are these two right here, which come up and join to form this one basilar artery, and then two internal carotid arteries up here, and these all form into a circle that connects with the basilar artery, and this area right here is called the circle of Willis. This is a very important area in the brain, okay? Note, these guys join, form this and this. These arteries then get distributed to all of the structures in your brain. So this is the entire blood supply to the brain, guys. You occlude an artery in this circle or anywhere in this system, and very, very bad things happen. This is the reason why keeping our vessels healthy is so important to the brain. The brain constitutes 2% of the body mass. It's actually very, very small, okay, 3 pounds or something. It requires 20% of all the oxygen that you take in. And that's because neurons are very metabolically active. They generate electrical impulses, they make membranes, they do all kinds of things, they process information. So it's like they're really energetic, you know, they're like the little Energizer bunny, okay? So 20% of all the oxygen that you breathe in has to go to your brain to keep it alive and working function. The brain has no mechanism for storing oxygen or glucose. If you're metabolically active, like you do a lot of aerobics or whatever, you utilize more glucose as well. So the brain is a very active organ, and so it has to have lots of oxygen, lots of glucose. And it turns out that within minutes of being cut off from its blood supply, ergo it's cut off from its oxygen and glucose, the neurons start to die. They're not replaced. Okay? So, this is that circle of Willis dissected out. I used to use this to teach medical students. Here's your two vertebral arteries. Here are your two internal carotids. By the way, as a side note, when the doctor listens on the side of your neck, he's listening to how the blood is flowing through your internal carotid. which is the one that's supplying a huge part of your brain up there, okay? And so it's going whoosh, whoosh, and they're listening to see if that's normal or whether it sounds like it's occluded. So your internal carotids are here, and again, these two guys form that one basilar, which gives rise to both posterior cerebrals. And to review again, posterior cerebrals are the ones that supply the hippocampus. Very important for memory, okay? Well, this shows something abnormal. This was, again, taken from autopsy where it was dissected out of a patient. This is a ballooning of the top of the basilar artery. It's called an aneurysm. So in an aneurysm, the vessel wall is weakened for a variety of reasons, and the blood pressure causes it to balloon out like a balloon. Well, that means, well, this person died, obviously. We couldn't have dissected it out otherwise. But that aneurysm would have caused a problem in the flow of blood in both posterior cerebral arteries. Okay? So this is just one example of how both sides of the brain can be affected by a singular vascular accident. Okay? Okay, global cerebral anoxia. One of the reasons why something like heart attack is very deleterious to one's health is that the heart, like the brain, has to get a blood supply and be normal, and the arteries have to be clear going to the heart. Otherwise, the heart muscle gets starved for oxygen because it's very active again, and it contracts and causes angina and pain. Okay? So it wants this normal blood supply. Well, the heart also pumps blood to the brain. Now, one of the things that matters here is that when you have a heart attack, what happens is you have decreased brain perfusion, okay? Because the heart isn't able to send the blood up to the brain. And so when you have a heart attack, you have cerebral anoxia, which means cutting the brain off from oxygen. Within minutes of decreased brain perfusion, again, neurons start to die. And when those neurons die, that's it, guys. You're born with more neurons than you're ever going to have again. And again, there is an exception to that rule, and it's going to be an important one that we're going to talk about. But nonetheless, in general, neurons are not replaced after they die. And so it's very important. It's one of the reasons that CPR and other things doesn't just help the heart contracted. It keeps the organs perfused and keeps the brain being perfused. Okay? So, the hippocampus, this is a sad thing, and again, this is a poor design. The hippocampus, for reasons we're not really sure, there's a lot of conjecture, but the hippocampus is one of the most vulnerable areas when it's cut off from its oxygen and blood supply. And we're not really sure why that is, but nonetheless it is. And so it's extremely important to take care of your vasculature. Okay? And in the last lecture in this series, I'm going to talk about ways to do that. Seizures. A seizure is an abnormal electrical discharge of neurons. So this is supposed to fire, this is supposed to influence that and whatever. If there's some tiny little area that's damaged in the brain, it can set up an abnormal electrical discharge where neurons are discharging when they shouldn't discharge. And there's lots of different kinds of seizures, okay? And there are seizure disorders. I'm sure all of you have heard of epilepsy. There are lots of different kinds of epilepsy as well. Seizures involving the hippocampus or an area around the hippocampus are called temporal lobe seizures because you remember the hippocampus is located in the temporal lobe. It's an old cortical area located in the temporal lobe. So all temporal lobe seizures are associated with some strange memory phenomena or loss of it. So for example, people that have temporal lobe seizures often present what's called déjà vu. They have what they think is a memory of something, or they walk in an area and they think they've been there before when they haven't been. And this is because the neurons are just sort of firing randomly. It doesn't mean that they've been there before. It means that their hippocampus is starting to show this abnormal activity, and it's giving them the subjective experience of, I've been here before. And other people say, no, you've never been here before. Deja vu. After individuals have seizures that involve the temporal lobe, they have what's called post-ictal amnesia. So ictus means seizure, so it's post-seizure amnesia. And they will show a loss of memory for some time surrounding the seizure because the hippocampus can't work normally with abnormal electrical activity going on. So it can't process things normally, okay? Repeated seizures can impair memory. So people who have repeated temporal lobe seizures that are not controlled do in fact show memory loss on tests of memory ability. And lastly, all generalized seizures. So what is a generalized seizure? A generalized seizure is one that involves both hemispheres of the brain. So this might be the closest thing I could think of that the lay public might have seen is on TV when they show a grand mal seizure where a person shows the motor and unconsciousness and other things, what it looks like to the public. By the way, real seizures really don't look like the ones on TV, but that's beside the point. Okay. All generalized seizures, except the ones that are the briefest, all of them cause some memory impairment. Yes. So ECT is electroconvulsive shock, and it's used as a treatment for refractory depression, and it's very effective for refractory depression. But nonetheless, there is amnesia after ECT, and it can be very profound. And while it normally decreases a little bit, the memory loss decreases a little bit, some people experience significant permanent memory loss after ECT. So ECT, for the treatment of depression, while it's extremely effective, isn't something doctors just say, oh, well, let's do this. Okay, so it is important. All right. Hippocampal sclerosis. So the word sclerosis means scarring. So it means that the hippocampus in the brain has had something happen that's caused it to be scarred. And a scar, just like if you cut your hand and a scar formed over it, there are specific cells in the brain that form scars in brain tissue when there's damage. There are mechanisms that the brain tries to wall off the damaged area and forms these scars. Hippocampal sclerosis, we're not really sure about this, whether it's the cause or the result of repeated temporal lobe seizures. Nonetheless, you can have it unilaterally or bilaterally, but it's always associated with memory loss. So this is an MRI, magnetic resonance imaging, where in a living person we can image the real brain. And on MRIs, it's as though you're looking at the patient, looking at them, and that means that the left is on your right and the right is on your left. Okay? So this is the left side of the person's brain. And right here, here's the hippocampus. It's tucked under in the temporal lobe. Here's the hippocampus on this side, which looks pretty normal. This is the left hippocampus, and we can tell by the way it looks, it's shrunken, and those clumps in there, it's scarred. So this is called hippocampal sclerosis. There's no coming back from it. There's no coming back from it. So now I'm going to ask you, left hippocampus is affected. Would you have spatial memory loss or words and episode loss? Word and episode loss. And that's exactly why in a person who's tested and you see that and you see everything else about their mental life is intact, that they want to look at an MRI and see if they in fact see this hippocampal sclerosis. There are people who do not have seizures who end up with hippocampal sclerosis, and that's very important to know that. A dear friend of mine, her husband was diagnosed with this, and I had physicians at Vanderbilt look at the MRIs. He had never had a seizure, and he showed bilateral hippocampal sclerosis, which was significant. And he had terrible memory problems, okay? Psychiatric disorders. Now, this is something that I think a lot of the lay public don't know, and that is many different psychiatric disorders are associated with memory impairment. So we used to think that this was just because people's brains, were busy, processing information in some other way or whatever, and that's why they have memory loss. We don't think that's true anymore. So we think that it is associated with damage in the brain that is the result of the psychiatric disorder. It can be primary in the disorder, and I'm going to talk about that. For example, in schizophrenia. So schizophrenia, or one type of psychosis, the individual processes information differently. The individual may have hallucinations and delusions. Again, this is the typical TV kind of thing of the paranoid schizophrenic. Most schizophrenics don't behave the way they're portrayed on TV. And with medication, many can have absolutely reasonable lives and live happy lives. Nonetheless, it's a serious disease. What's been discovered is that at least in some large group of schizophrenics, they are lacking one specific type of neuron in their hippocampus. And the fact that they don't have that neuron in their hippocampus means their hippocampus is not processing information normally in order for the short-term memory and eventually long-term memory to take place normally. So it means that if you test these individuals on memory tests, they have significant loss or score significantly lower than normal individuals. And so this is primary. It can also be secondary. And this is something, I try to stay away from the jargon, but sometimes you just have to do it. Secondary. Psychiatric illness is very stressful. For any of you who have people in your families who have psychiatric illness, it's very stressful on the person who has it, it's very stressful on the family, it's stressful on the dynamics of interactions. Well, what stress does is stress alone, regardless of whether you have a psychiatric illness or not, stress activates what is called the hypothalamic pituitary adrenal axis. So what that is a mechanism in your brain that basically has connections that cause cortisol, stress hormone, to be released into the bloodstream to prepare you for fight or flight. Okay? And so this is a system that when you're under stress is to alert you and to make you make a decision about, do I stay and fight this enemy or do I run? The brain doesn't make any distinction between psychological stress or stressors and physical stressors. So the system evolved to protect you, like when you see that saber-toothed tiger, that you're running before you recognize that it's a saber-toothed tiger. If you didn't have some mechanism for doing that, you get eaten. Okay? Nowadays, it's psychological stress. Every time you're driving your car and the traffic drives you crazy, you feel your heart starting to pound and you get angry, road rage. This is a hyperactivation of a part of this system. It responds to stress. Okay? Well, in psychiatric disorders, like depression, for example, there's a hyperactivation of the system. And here is the problem. All that cortisol that's being released into your bloodstream that activates you and makes you angry and you feel very stressed and all of the changes that go along with it. Cortisol, of course, is in the bloodstream, so it goes to the brain. Well, unfortunately, it kills hippocampal neurons. So chronic stress, whether it's brought about by a psychiatric illness like depression, which can be very stressful for people who suffer from this disorder, or chronic stress for any other reason, and a lot of times, think of your own experience. Like at times in your life when you've been very, very stressed. There are huge things you can't remember, and usually we're aware of that. Like, for example, if you lose a loved one, and you go to the funeral and you're just completely in some other place, and later somebody says they talked to you or they did this or something happened at the funeral or whatever, and you're like completely oblivious that that thing ever happened. So some of it can be situational and be temporary, although the memory loss may be permanent. But if you're under chronic stress, and that is what depression does, if you're under chronic stress, then you're stressing the hippocampal neurons and can actually kill them. So, that's important.
Does the use of the drug cortisone have any similar impact?
That's a little different. You don't take steroids over long periods of time, and you take very low doses. So that's a little bit different than natural cortisol in response to stress. Okay, and now I'm going to try to get this to work. Okay, abuse. This is one of my areas of interest, and I put this in here because I know a number of you in this room are psychologists or counselors or work with people, and all of us have loved ones that we care about. Well, turns out abuse is a big thing in our society, okay? And there's some studies in neuroscience that have really only come out in about the last 10 years, and they're really, really important. And that is, originally, it was found that people who had been abused as children, and whether that abuse was emotional, sexual, or physical abuse, were more prone to psychiatric disorders. Okay, anybody think that doesn't sound odd to me? Okay, as adults. So then they discovered that people who have psychiatric disorders have more problems with memory. So then somebody came along and said, well, let's separate out the people who have psychiatric disorders who were abused as children from the people who were abused as children and haven't been and are now adults who don't show any type of psychiatric disorder. So what I'm talking about here is memory impairment in adults who were emotionally, physically, or sexually abused as children who do not have any recognized psychiatric disorder as adults. So it's your person who seems perfectly normal individual who 50 years ago suffered some kind of abuse. Turns out that when MRIs were done on these individuals, they could show that the left hippocampus was decreased in volume, and that the amygdala, if you remember that amygdala is involved in emotional memory, it's hyperactivated in people who were abused as children, even if they haven't been abused for the last 50, 60, 70 years. Okay? That chronic activation activates that HPA axis that causes cortisol to be released. So you have individuals who seemingly can be perfectly normal and adjusted, who haven't suffered any abuse for a very long time, who still show changes in their brain that are significant enough to quantify on MRI. So, this is important for all of us to know who have friends who were abused as children or one thing or another, that people need to seek help and do what's necessary truly to deal with these sorts of things. The brain changes underlie memory impairment. You can show on memory tests that these people, even if they're very successful individuals, in fact do not have a perfectly normal memory. And so this is a long-term thing that was done because of something that happened in childhood. Okay? And these individuals also show this hypervigilance. One of the interesting things that came out of a number of these studies, and I'm trying to summarize over hundreds of studies, one of the interesting things that came from it is the greatest changes in the brain for males occur after emotional abuse, and the greatest changes in the female brain come after sexual abuse. And in sexual abuse and emotional abuse, the greatest changes occur in individuals who were either emotionally or sexually abused by a member of a family. And so this too, it means that the brain reacts to things that happen to us in our lives. And even if we're unaware that we're hypervigilant, the brain is always vigilant after something potentially threatening to life. And I want you to think of a small child as totally dependent on their parents, being abused by that parent, for example. This leaves a permanent scar on the child. And so whatever ways we can intervene or what we can do are very, very important for children to try to keep this from progressing as they age. Neurodegenerative disorders. Okay, so this is our big one for today. There are a number of neurodegenerative disorders. So again, let me stress, the term neurodegenerative only means that there's degeneration or death of neurons in that disorder. So there's a huge number of these disorders. And many of them, let me stress, can cause memory loss. Alzheimer's is the prototypical neurodegenerative disease that results in memory loss. And I'm going to lead you into why that's so based on what we've covered in our class since we've been meeting. So I want to look at first historically. You hear the term dementia used. Dementia just means a progressive mental decline, a progressive mental deterioration. Memory is only one thing of a mental life. There are many other aspects of it, and we'll come to that in a minute. But dementia is just a general term, like fever. Fever can be caused by many things. Well, dementia can be caused by many things as well. Okay? Alzheimer's is just one type of dementia. So Alzheimer's is called a primary dementia. And what I want to stress with you, it's progressive, often slowly progressive, and irreversible. I want to focus on the irreversible here, okay? They're early onset, which generally means before 65. It's arbitrary. Some scientists and physicians cut that time off at a different place. And late onset forms, like, that occurs after 65. Alzheimer's is the most common primary dementia in the United States, okay? And the most common neurodegenerative disease. Right now, 5 million people have been diagnosed. And it's estimated to go skyrocketing as all of us baby boomers enter that over 65, because that's more common, okay? So again, I want to stress, there's early onset and there's late onset forms. There's a reason why we separate these this way. Okay, so the two forms, early onset. This is called early onset familial Alzheimer's disease. That, having that term in there, means that it's genetically transmitted. Okay? In early onset familial, if you inherit the disease, you get the disease. There's no escaping it. If you live long enough, you'll get the disease. So it's transmitted in what we call autosomal dominant inheritance, which means you inherit the gene, you get the disease. Okay? In a recessive disorder, you have to inherit the gene from both parents. And if you inherit the gene from only one parent, you won't generally show the same signs and symptoms. It's not like an autosomal dominant disorder. You get the gene, you get the disease. Now, the good news about this is that it accounts for a very small number of cases. It's only about 5% of the cases of individuals who get Alzheimer's disease. Remember, you inherit genes from your mother and your father. So if one side has the gene, you might not get it. Okay, so it accounts for a very small number of cases. Late onset, which is what we're going to focus on, that most people are afraid of for good reason, is called late onset sporadic, meaning it's not genetically transmitted, it just happens for causes unknown in the population, Alzheimer's disease. There may, in fact, be multiple causes or etiologies. That may be why we're having trouble pinpointing a cause for this disorder, although I think we're moving very, very close. And I have a star here, and I'm going to come back to this next time. The current top etiology is that Alzheimer's disease is actually a secondary disorder to what we call cerebral vascular dysregulation that is occurring at record pace in the United States because of our poor exercise and eating habits. Okay? So I'm going to come back to that in the last talk and talk about why in industrialized nations this disorder is going wild, okay? And in other cultures, it isn't, okay? So, you know, epidemiologists look for these little hints as to what that might tell us about it. This type is associated with various risk factors that change the probability of developing the disease. And it's really important to stress the difference between autosomal dominant inheritance. You get the gene, you get the disease. 100%. Down here, this type is not genetically transmitted. There's a lot of different risk factors that increase the probability, and there are also risk factors that decrease the probability you get it. And that's what we're going to talk about in the last lecture, how to increase the ones that decrease our risk. Okay. I want to talk about how people change, and I want to make a really important point here. Every one of you is an individual human being. And what you remember, how you relate to the world, who you are emotionally, your personality, temperament, all these things are individual. When a neurodegenerative disease starts taking cortical neurons and killing neurons all over the brain, how you behave will be slightly different from how I would behave if I got that disease. So every Alzheimer's patient, in some sense, is very individual because that disease is taking away their memories, taking away the way they respond to other people, taking away their mental activity. Nonetheless, there are some common ways that people behave. So these are the common ones, okay? You may have members of your family or someone you love and know who behaves differently, but in general, this is how it progresses. One of the first things you see is memory loss, particularly short-term memory. And this can be spatial or for words or things. You have a person who's gone to the movies every Friday night, and now they can't remember how to get there from their house. Okay? You may not notice that they've forgotten it. My friend, one of my best friend's husbands has Alzheimer's, and they used to go to the movies every Friday night, and she noticed that he started asking her to drive to the movie on Friday. And she didn't think anything about it. The truth was he couldn't remember how to get there. She didn't know that. Okay? Decreased initiative. Part of this involves, I was reading a case history this morning of an individual that the first thing in retrospect that his wife noticed had changed was that he used to love to read and suddenly he stopped reading, period. He stopped reading. The person doesn't want to do things they've always wanted to do, like a man who likes to go fishing all the time suddenly doesn't want to do it anymore. A woman who loves to get together with her friends and do something doesn't want to do it anymore. There's a decreased initiative. This also can involve personal habits. So, for example, the person who's always been fastidious about their dress or their hair or whatever suddenly doesn't care anymore. And others who know them notice, but they think, Aunt Jeannie's just getting old, or whatever. Okay. Depression. Depression is now believed to be primary in this disease. So it's a depression not just because the person is recognizing something is going wrong with them. It actually is primary in the disease. It's part of the disease process itself. Faulty judgment, loss of insight, and other higher order functions. This faulty judgment, a lot of people say when they look back at their loved one and their loved one's behavior, they notice that faulty judgment was very serious, like very poor decisions in investing money, lots of other things that involve decision making that just seemed really kind of screwy, okay? And at the time, you just pass it off, and the person themselves is, their brain's just working the way it is. So these are very common, very early changes. As the disease progresses, you see profound memory loss. Now we see working memory is gone, short-term memory is gone. This is why you can play the same movie. Another friend of mine whose husband has Alzheimer's, she used to play the same John Wayne movie over and over to her husband because he couldn't remember that he'd seen it before. And when she'd ask him what had gone on in the movie, he couldn't tell her. His working memory was gone, his short-term memory was gone, and she just played the same tape over and over and over again for him. Additional changes in higher order functioning. One of the things that happens is people get to the point where they don't understand jokes anymore. And I don't mean that every once in a while that you don't get a joke or something. I'm talking about people, that's a very subtle thing. The best jokes are the ones that turn on some subtlety. And the person loses the ability to process that subtlety. And so they don't get it anymore. And they don't understand why everyone is laughing at something. It doesn't make sense to them. Then you have behavioral mood disturbances. You have what's called sundowning. There's a reason for this. The amygdala that's involved in this emotional memory. The amygdala is one of the things, structures that degenerates in this disease. And what happens is during the evening, for reasons we're not exactly sure why, but during the evening the person starts getting really anxious. They're frightened. And they don't know what they're frightened of, and it's due to hyperactivity of degenerating neurons in the amygdala. And so the neurons are dying and they're discharging sort of randomly, and there's lots of biological clocks in the brain, and this one just seems to activate sort of at this time. Hypersexuality, in my opinion, is one of the most difficult phases that Alzheimer's patients, not all go through it, but many do, and it can be short-lived, but nonetheless is traumatic for the caregiver and traumatic for other people who know them. So imagine you're a teenage boy. Imagine you're a teenage boy and your father has Alzheimer's disease. Well, let's imagine that you have your friends over and you're all in the living room, and down comes your father down the stairs, stark naked, playing with himself. What do you think kind of effect that's going to have on that 14-year-old? Very traumatic. Do you think it's going to lead to a lot of anger at the father? Absolutely. Do you think a 14-year-old can process that dad can't help it? Because in other ways, dad seems, halfway there most of the time. Well, this is the kind of thing that happens. The other thing, 1 year in the medical school class, we had a man come to the class and talk to the medical students. And we all, a lot of times we think of women as caregivers. Well, when men are the caregivers of an Alzheimer's patient, this can be very traumatic. They may not be used to the role. We do have different kinds of roles that men and women take. Particularly those who are older and part of an older generation. And he said that he told the medical students and talked to other people as well that his wife had always been the most dignified individual. And when she got Alzheimer's disease, she would do lewd things and try to get him to have sex with her. And he said initially he had sex with her, and finally he couldn't do it anymore because he felt it was like raping a child. And he said his wife would rather be dead than behave in the way that she was behaving. And that it traumatized him to see this woman that he had loved, this dignified lady, lose that dignity. And usually this is very short-lived, which is good because it is traumatic for caregivers and traumatic in front of other people. It can manifest itself in many different ways, and your imagination will serve you well there. Late in the course of the disease, the person's left hippocampus is basically gone, and this is the left hippocampus, you may recall, is the part of the brain that strings together the episodes of your life into an autobiography. So the person no longer knows who they are. It's not just that they don't know who you are, they don't know who they are. They don't have anything to tie them to the events of their lives because those neurons are dead. And so they can't tap into a self. they have profound memory loss, and now it includes long-term memory as well. So now they just completely have lost their connection to their personhood and to their humanness in some very, very important way. They often become paranoid. Some people do, some people don't, but often do. They show emotional lability or instability and little impulse control. So the person can be just up and down and just can't control their impulses. So, for example, the person starts to eat. Well, they start to eat, and then they just eat, and they just eat, and they just eat, and they don't stop. And they can literally have a diaper on that's full of feces, and they continue to eat, and this just continues as a process. I want you to imagine taking care of somebody like this, who can't understand when you tell them, no, not to do that. And even more dangerous, the person may start eating things that aren't edible. And so they may see a perfect example is a fruit bowl where there's always been fruit throughout their lives. Well, their brain kind of has a connection that there's fruit in that bowl or there's something edible in that bowl. But now there may be artificial fruit in that bowl. And the person will just start eating it and not stop. They end up with ruptures of their stomach and intestine, their esophagus. They choke to death. They have other problems because once they start, they can't stop. There's no impulse control. There's no stopping what gets started. It's like a program just gets going, and there's no rationally talking them out of it. You have to watch these people all of the time. And the burden on the caregiver is just enormous. To have to watch someone and make sure that they're safe and to keep them safe. Severe language deficits, sorry, I pushed the wrong button. Severe language deficits or muteness. Language is a very higher order function, and so it is lost. And over time, people may say only one word, go, 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 now. Now I want you to imagine a person saying go all day long and all night for 4 days without stop. This is not just somebody says go, go, and then that's it. This is a person whose brain starts doing something like that and they can't stop it. And so they'll repeat one word over and over again. They may not sleep for 4 or 5 days. There are certain areas of the brain that control sleep-wake cycles. This is an area that degenerates, so these people have that all thrown off, and so they can be awake for 4 days. Now I want you to imagine being the caregiver of somebody awake for 4 days. And you're trying to make sure that they don't do something, leave the house and get lost or hurt themselves or one thing or another. So again, this is really serious. Cachectic and incontinent. So cachexia is where a person starts showing severe wasting. So the person may eat like crazy, but they start showing wasting of the body. And generally by the time someone dies with Alzheimer's disease, they really look bad. They look like an advanced cancer patient, so they look very cachectic. And the other thing, of course, is the incontinence. And once you imagine a person who can't process information, and you're trying to change their diaper. Imagine a woman my size trying to convince a man who can't process language and doesn't know who I am that I'm trying to help him. And he's 6'3" and doesn't know who I am and is scared. And imagine the battle that's going to ensue with that. Okay? So this disease doesn't just affect the poor individual who gets afflicted, it affects everybody, everybody. Death generally occurs secondary to pneumonia or some other infection or from cerebral hemorrhage. Now, the reason for this. The pneumonia occurs because people who are bedridden, part of what you do when you walk and you're a normal person, you do aerobic exercise, you move and everything, part of what happens, you expel bacteria from your lungs. This is a normal thing that happens. If you're bedridden and you're not moving and you forget how to swallow, you're building up all kinds of secretions in your lungs that are full of bugs. And so you get infections, get pneumonia, and die secondarily from that, or from cerebral hemorrhage. The same kind of abnormal crap that's getting deposited in the Alzheimer person's brain is getting deposited in the blood vessels throughout their body. But in the brain, what happens, it weakens the wall of the vessel, and so the vessel leaks blood. And so one of the most common ways that a person with Alzheimer's dies is from cerebral hemorrhage. So they bleed into their brain. What happens in the brain? Okay, what do you have? Memory loss. Okay? What did I tell you, like in lecture number 1 or something? You have primary areas. Primary motor cortex, you initiate a motor movement. Primary somatosensory, you feel something. Primary visual, the first area to process visual information. Everybody with me? You remember that, right? Okay. In Alzheimer's, it's everything else that dies. And that's why the person can still see, they can still hear, they can still move, and they can still feel. They just know what it means. They can't process beyond that. So what do? This is the first area to process visual information, but you remember those secondary higher order areas I told you about that tell you what something is, or who someone is, or what you do with something. So for example, if I were to hold up, let's imagine that I hold up a fork, and I ask you all, can you see it? And you'll all say yes, right? Okay? And then I ask you what it is, and you say fork. And then I say, what do you do with it? And you say you eat food with it. Okay? The person who has Alzheimer's can see the fork. They just don't know what it is or what it's used for. Now, while some neurons are still firing off there, like my friend whose husband, one day I sat at the table, so watching him when I was visiting, she got to go off and get ready for what we were going to do while I sat with him. He picked up a cup of coffee, and he took the fork and he tried to drink the coffee with a fork. Now notice that some neurons were still working. He got the idea that what was in the cup he wanted to get to his mouth, and he got the idea that the fork was used somehow in eating or something. But do you see how it's not right? Okay? And then later, he tried to eat something with the wrong end of a knife. So you see, there's still something going on there about this is used for eating. And later in the disease, he now no longer knows what up or down means, or basically anything about what something is or what it's used for. He can still walk, he can still see, he can still feel, he can still hear. And that's because, again, it's all the other areas of the brain that are gone. The hippocampus, the frontal cortex. Notice here, executive function. Prioritizing behavior, using morals to decide what you're going to do, executive planning, working memory, impulse control, all the things this area of the brain controls, that area of the brain's gone. It isn't there anymore. It's gone. Okay? So, the first area that undergoes degeneration, because our topic here is learning and memory, the very first area to go is also located in the temporal lobe, and I didn't mention it. Again, I'm trying to keep the jargon down. But when information comes into the visual system, visual cortex, it comes into auditory cortex, it comes in these other areas, it all then converges on an area called the entorhinal cortex. And it's in the temporal lobe, and it's a cortical area that processes information across all the sensory systems and then communicates this information to the hippocampus. So if I want to remember that my friend's name is Norma, then I have to associate what she looks like, what she sounds like, my memory in the past of interactions with her. All those things have to come together, okay? So the entorhinal cortex is the area where it brings it all together and then sends it to the hippocampus that then decides, is the current thing that's happening a memory or is it a novel experience, okay? So this is the very first area that shows degeneration in Alzheimer's disease. Now you can understand why the person, has problems processing things related to memory, because the very first thing you do is go across the sensory systems. That's the information coming in. Well, if that's not being processed right, then nothing else related to memory can happen. Okay? The hippocampus degenerates early on, and degenerates means the neurons die. I want to emphasize that. And that's why short-term memory is lost. The prefrontal cortex degenerates. That's why working memory is lost. And finally, late in the disorder, remember that long-term memory involves widespread areas of the cortex, but these neurons are gone. And that's why long-term memory goes. So, first entorhinal cortex, then hippocampus, working memory, long-term memory. And it follows the progression. Okay. This is an individual with Alzheimer's disease and what their brain looks like. And this is a person of the same age who does not have Alzheimer's disease. And I show you this to emphasize again, so many neurons are dead that the brain is significantly smaller. Was there a question here?
Do you think that STEM research or anything in that way will be able to recreate or regenerate neurons?
No. Okay? Do I think you can grow neurons in the brain? Yeah, you can, but it's not going to restore your memory because your memory was embedded in the cells that have died. So you might be able to make new memories with like stem cells implanted in your hippocampus. You might be able to generate neurons and have new memories. You're not going to have your old memories. They're gone. This person's memories were gone. Okay? And I want you to see, this is someone asked me this morning, as you age, does your brain get smaller? Yes, if you were to see over here in a third panel, a normal brain of an individual 17, yes, this brain has undergone changes. That's nothing next to that. Okay? Dementia is a disorder. It is not normal aging. Okay. Changes also occur at that cellular and molecular. I told you guys this wasn't going to be a happy lecture, okay? Changes also occur at a cellular and molecular level, and I'm not going to go into detail about this. Again, I think you need to have a background in biochemistry and other things to really appreciate this, but you hear about this on the news, so I wanted to at least mention it. So we've already loss of neurons within the cortex. That's why the brain looks so much smaller, because the cortex is so much smaller. Okay, that's obvious. But now, loss of synapses and the connections between those neurons. A single neuron can receive 10,000 synapses. If that one neuron dies, you lose all the connections that neuron had with everybody else. You lose all the synapses that that neuron had. So it's estimated that people with Alzheimer's are losing hundreds of thousands of synapses a day. A day. And when they're gone, they're gone. Okay, so that, that's important. Now, this is what you hear about on the news, which never makes sense to anybody. You have accumulation of the brain, and this is where people have been interested in looking at what's going on in this disease so that we can try to figure out what's causing it, what's going on. Accumulation of altered proteins. I want to stress to you, the proteins are normally occurring proteins that have a function in the brain. And in this disease, something goes awry, and they either have side groups, meaning other molecules that attach to them, or they don't get cleared from the brain normally, or something that goes awry. So the protein is altered, but the protein itself is a normal protein that's found in the brain. Within remaining neurons, you have intracellular changes, and these are a specific protein, for those of you who care, called tau. Alzheimer's disease to a pathologist is called a tauopathy, which means a pathology of tau. So there are many tauopathies, of which Alzheimer's is only one, okay? So these are intracellular changes, meaning within the neuron, that eventually results in death, we think. And neurofibrillary, these are also called neurofibrillary tangles. And you hear that term applied to Alzheimer's. And deposition of a protein called beta amyloid, which again is a normal protein in the brain, has a normal good function, somehow gets altered within the brain. This is extracellular, and that's what's meant by plaques. So this is identified at autopsy. This is a neuron that's so filled with abnormal tau protein that you can see it stained like this with particular stains. And this huge thing is outside of neurons, but is an abnormal thing that's been deposited in the extracellular space. This is a plaque. So we say that pathologically, Alzheimer's disease is a disease of neurofibrillary tangles and plaques. And you hear those terms used. And what that means is that on autopsy, we will see all of these changes in the brain. So, keep your memory sharp. Avoid head injury. Okay, yeah, usually you don't have any choice. Sometimes you do. Wear that helmet when you go for a bicycle ride. Okay? Keep your arteries healthy. How do we do that? By staying close to the earth with what we eat. Okay? Keep your arteries healthy. Be compliant with meds to avoid seizures if you have a seizure disorder, so that no matter what kind of seizure disorder you can have problems with memory. Be compliant with your meds that keep you from having the seizures. Treat psychiatric illness. Psychiatric illness is a real illness and it has long-term consequences for the brain. Treat it. You know, and if you have any attitudes about other people that have psychiatric illness, examine that attitude in yourself, because it's one of the reasons why people with psychiatric illness won't seek help, because they're afraid that other people will look at them a negative way. And it has a very negative connotation and stigma. And so as a society, we need to remove that stigma so that people will seek help, appropriate help, and be treated. If you were abused as a child, seek help. We can show that cognitive behavioral therapy in which people are helped both behaviorally, meaning in how they do, and cognitively in how they respond to events in their life, can in fact decrease that hyperactivation of the amygdala and start decreasing the stress load on the hippocampus. If you were abused as a child, do not think because you're a successful, great, wonderful person today that it hasn't left its effect on you. Seek help. If you know of people who are children who are being abused, do what you can to stop it. Okay? Decrease stress in your life. Yeah. That's an easy one to say and a hard one to do. And practice mindfulness meditation. You know one of the things mindfulness meditation does? Yeah, lowers your blood pressure. It decreases cortisol secretion, decreases activation of the hypothalamic pituitary adrenal axis, decreases the cortisol that kills your hippocampal neurons, and brings your awareness in a positive way to your life. And last of all, okay, decrease factors which increase your risk for Alzheimer's disease. And that's what our last lecture is going to be about, what you can do every day of your life that will decrease your risk for sporadic Alzheimer's disease. I can't give you any advice about decreasing anything if it's genetically transmitted, obviously, but for the vast 95% of people who get Alzheimer's, it's the other type. So we're going to talk next time about how to decrease that. Yes? Generally, if they're within, whether contusions can be seen in a live person, if they do an image of your brain, they often can see something. They may or may not do that. It generally clears, though. The blood is removed from the brain over time and everything. Yes?
Yes, ma'am. For these children that you hear that have, like, they're born with constant seizure syndrome, they're never going to have any memories, correct?
Well, I mean, it's not that they don't have any. It's that they'll always be memory impaired. Okay? It's not that there's no memory. It's that they're memory impaired. It will never be normal. And there's some questions farther back. Yes?
Can you clarify the difference, if there is any, between dementia and Alzheimer's? Like,
yes.
That
yes.
Dies literally
Yeah, no. Okay. Dementia is a general term. And there are lots of different kind of dementias. Alzheimer's is one. So the word dementia is just A big term. It just means progressive mental decline. Alzheimer's is one dementia. There's Lewy body dementia, there's frontotemporal dementia, there's all kinds of dementias. Alzheimer's is just one dementia. Okay? Yes?
Go back to the head injury. What if you hit your head on a cabinet? What is the head injury? How extreme is a head?
Well, you know, it's hard to tell. I have to tell you, you could have what appears to be a minor hit, and you could die from that. So you could have a minor hit to the head and cause things going on in your brain that would result in death. And you could have another hit that was 10 times harder or 100 times harder and not die from it. So it depends on how you're hit and what's affected when it is hit. Okay? Basically, remember, this thing in our head is so valuable that bone, you know, is around it, right? So that's to protect us. So just don't get head injury no matter what. You could sustain really, you could have a minor hit to the head, and if it causes bleeding in the brain, you could die from it. So it's not just the force, it's lots of other factors play a role.
Can frontal brain injury cause psychopathic behavior?
Yes, that's what Phineas Gage had. So Phineas Gage was the famous patient that had a tamping bar go through the front of his brain. And he became an entirely different person because the prefrontal cortex was involved. Yes?
Fainting due to vasovagal syncope. Do you lose memory because you're passed out?
You can if it's, yes. Yes. Minor. Okay? Yes?
Your arteries healthy needs to be spelled out, I think, a little bit more by exercise. One of your colleagues at one of your other lectures 2 weeks back.
Next week. That's what we're going to talk about. The one thing you can do that will change your life. Exercise. Okay? Yes. Next week, that's what we're going to talk about. Yes.
Maybe you're going to address this next week too, and I apologize if that's the case, but let's say that in fact you have late onset Alzheimer's at a very, very early stage. You're not even aware of it yet, but it's there. You've spoken about the fact that it's progressive and irreversible, but if you started following a certain regimen,
You might slow the progression. It is irreversible, but you might slow the progression. And just to address this, I'm going to tell you that most neuroscientists and experts on Alzheimer's disease believe the disease starts in your 20s. And that you simply don't see the manifestation of it till much later. Okay? It's a disease in which we think the changes are slowly progressive and irreversible, and that some of the changes that could lead to this disorder are started in the 20s. And I'm going to make a mental note to tell you a major study that was done that was part of why we think that. Yes?
I hear about drugs. Do they remove plaque? What are they doing to slow the progression?
Okay, so one of the areas that degenerates is a subcortical area that lies beneath the cortex. And this is a tiny little nucleus, and if you care, it's called the nucleus basalis of Meinert. It's a little tiny nucleus, and it was in that slide on memory. But that little tiny nucleus provides the neurotransmitter acetylcholine to the cortex. And it turns out that neurotransmitter is important for normal cortical functioning. And whenever that little nucleus degenerates, you get some type of dementia. Okay? Whether it's Alzheimer's or some other type. Okay? So early in the disorder, when your doctor thinks that maybe something is wrong, he might prescribe a drug like Aricept, which is actually donepezil. And donepezil increases acetylcholine to the cortex. So now your little nucleus basalis isn't working right, so now the doctor gives you externally what's missing, what neurotransmitter is missing. And early on, some people say, and even the person in early stage of Alzheimer's will say, you know, I do feel more mentally alert, and I think my memory's a little better, and the husband or wife will confirm that they seem a little bit better. Then later it doesn't work anymore. Once the cortical neurons start to die, then providing that acetylcholine isn't going to do anything. All right, does that make sense to everybody? I want to make sure that makes sense. If you've been in this class, it should make sense to you. Yes, Larry.
Many of us in this room have served in the services. 60 years ago, when somebody, if they survived at all in Korea, one deployment. Today we're seeing 3 and 4 and 5 and 6 deployments of these people, and they come back with serious PTSD problems. Now, is there sufficient research and effort going on now to try to help some of that?
Oh my heavens, there's just an enormous amount of research being done. And our understanding of PTSD, which is post-traumatic shock, a stress disorder, what you see in children who were abused, who haven't been abused in between, is basically a mild PTSD. This long-lasting has been going on for their entire lives without them realizing it. So individuals, men and women who serve in the armed forces, come back after they have head injuries, they have other things, they have PTSD, which involves hyperactivation of amygdala and hypothalamic pituitary adrenal axis, which means that cortisol is floating around killing their hippocampal neurons if the head injuries didn't do it. And so, yes, and there are a lot of counselors now and psychologists and people who are specializing in helping people with these things. So,
visual things that they've seen.
Well, yes, it's very traumatic. I mean, you can't raise somebody for 18 years and tell them to be loving to everybody else and then give them a gun and tell them to go kill somebody without it being fairly traumatic. I mean, it'd be traumatic for me, okay? So, you know, even if you believe in what you're doing, it doesn't mean it isn't traumatic to see another human being against whom you don't personally hold any feelings one way or another. To kill that person is traumatic. And we need to be aware of that in the decisions we make as a society and every other way. Yes?
Does alcohol affect all of this?
Yes. Alcohol, the hippocampus, and this little structure back here, the cerebellum. So the cerebellum, that's why you can't walk straight when you drink too much. But if you drink a lot over time, you develop this disorder called Wernicke's encephalopathy, which is permanent memory loss. And that's because you've rotted your hippocampus. Okay? You've pickled your hippocampus. Yeah. Yes. Memory loss following anesthesia and chemotherapy. Yes? Okay. Number one, anesthesia is a drug-induced coma. People do have slight memory loss after anesthesia, and generally if you're a normal person, you know, you're okay and you go on. Repeated anesthesias can have a significant deleterious effect on memory. And I'll tell you, you shouldn't have surgery unless you need to have it. Okay? You shouldn't be put under anesthesia unless you need to be put under anesthesia. And this is important. This is important, guys. Your brain can't handle these things. Chemotherapy, remember, chemotherapy is a poison. You're trying to poison rapidly dividing cells that are forming a tumor or forming the cancer. When you give a poison, you kill those guys, but you have to give it in high enough dose to get all of them. So that means some normal guys get it too. Well, that poison is going to affect your brain, and so you're going to kill neurons. I mean, you're going to kill neurons. And some of these areas involved, memory is a labile thing. Were you all here last week? Well, you know, memory fails us in predictable ways, but it's an electrically encoded event. You do anything that disrupts that, then you have some kind of memory loss. Now, many people have been under anesthesia, had chemotherapy, and had lots of other things, and do just fine. So it's a risk thing. It's a risk. It increases risk for memory loss. It doesn't guarantee you're going to have memory loss. It increases risk for it. And it's really important to know the difference between it causes memory loss, you lose all your memory, versus it just increases your risk. And other factors about you and the health of your brain influence that risk.
Are some people more susceptible? Okay, so like not all brains are the same.
Yes.
So, for instance, in an abuse case, if you have siblings, one may be very affected by the cortisol levels over time, and the other may not.
It's good that you point that out.
Why is that?
One person may seem more affected than another, but if you actually look at the scans, you see that changes have occurred in both brains. The degree of change might be different, but the people I'm talking about who had abuse as children don't show any psychiatric problems as adults. They seem like perfectly normal, adjusted people. So it's not like it's obvious they were abused. In fact, it's not obvious that they were abused. And so it's the change in the brain that matters. And this, again, is a risk thing. Yes, are some people more susceptible to these changes? I mean, yes. And we think one of the things that interacts is temperament. So temperament is what you inherit genetically, how you respond emotionally to the world and events. Your temperament interacts with what happens to you as a kid, and so people with certain temperaments are more likely to show these long-term effects of abuse than kids with other temperaments. And two kids in the same family can have two different temperaments. I think they're going to throw me off again, guys. All right. Next